Okay, let's unpack this. We're diving deep into a set of sources that tackle two of the most common and frankly most challenging problems in medicine: chest discomfort and abdominal pain.
Yeah, really common, really challenging.
Think of this deep dive as getting a glimpse into the medical detective work that happens every day when someone walks in with these symptoms.
Exactly.
Our mission is to navigate this material, pulling out the core insights, the surprising facts, and understanding why diagnosing these can feel like trying to solve a puzzle with half the pieces missing.
It really can feel that way sometimes.
We'll look at the vast landscape of what these symptoms could mean and how the experts think about figuring it all out.
And the challenge is immense because the stakes are so high. As our sources show, these are incredibly frequent complaints, yet they can represent anything from something completely harmless, which is, the vast majority,
Right.
to something that needs immediate intervention to save a life. That tension between common benign causes and rare, life-threatening ones is really at the heart of the difficulty.
Absolutely. Yeah. Let's start with chest discomfort, because the sheer scale is staggering according to this material. It's one of the top reasons people head to the emergency department in the U.S. We're talking 6 to 7 million visits every single year.
Just the volume alone is a challenge, isn't it? And as you said, the core difficulty is that while there are hundreds of possible causes, a small handful are immediate threats that absolutely cannot be missed.
Yeah, you can't miss those.
Our sources lay out the initial thinking process by putting potential causes into three broad buckets. First, myocardial ischemia, meaning heart muscle isn't getting enough oxygen.
Okay.
Second, other cardiopulmonary issues, which is basically other heart and lung problems beyond simple oxygen deprivation.
Got it.
And third, everything else, the non-cardiopulmonary stuff.
That framework helps categorize, but it immediately highlights that balancing act. You have to be lightning fast to spot those high-risk conditions, but the sources also caution against the reflex to just test everyone extensively, which can have its own downsides.
Exactly right, because when you look at the numbers our sources cite, despite that massive number of ED visits and a high hospitalization rate, over 60% of these patients are admitted to the hospital.
60%? Wow.
Less than 15% actually end up being diagnosed with acute coronary syndrome, or ACS.
Wait, over 60% hospitalized, but less than 15% have ACS. That's a huge mismatch. It means a vast amount of medical effort and resources are being poured into evaluating people who ultimately don't have the scary heart conditions everyone is worried about.
Precisely. And the sources spell out what those other diagnoses often are. The most common causes overall are actually gastrointestinal issues, making up as much as 42% in some studies cited.
42%. GI. That's surprising.
It often is surprising to people. Muscle and bone issues in the chest wall, what they call chest wall syndrome, are also very common, around 28%.
Okay, here's where it gets really interesting and underscores why this diagnostic process is so critical. This statistic is quite chilling. Historically, even with all that effort, between 2% and 6% of patients sent home from the ED with chest pain that wasn't thought to be ischemic were later found to have had a missed heart attack. And tragically, these patients had double the risk of dying within 30 days compared to those who were admitted.
That's the statistic that keeps clinicians up at night. It perfectly illustrates the central dilemma. How do you confidently identify the tiny percentage with true urgent heart issues among the massive percentage with benign causes without over-testing everyone?
It's a huge pressure. Let's dig into those causes, starting with the big one. The heart itself. When we talk about chest discomfort from the heart muscle not getting enough oxygen, that's called angina pectoris.
Right, angina. It's essentially a supply and demand problem. The heart needs X amount of oxygen, but it's only getting Y and X is greater than Y.
Okay, simple enough concept.
And the sources are clear. If that imbalance is severe and lasts long enough, sometimes as little as 20 minutes, it causes irreversible damage to the heart muscle cells.
Just 20 minutes.
Sometimes, yeah. That irreversible damage is a myocardial infarction, or an MI, what most people call a heart attack.
And the usual suspect behind this is fatty plaque buildup, atherosclerosis, narrowing the coronary arteries that feed the heart muscle.
Exactly. This leads to the distinction between stable and unstable heart issues. Stable angina is like a predictable traffic jam. The narrowing is gradual, and the pain usually happens with predictable stress or exertion.
Makes sense.
It goes away quickly with rest or medication like nitroglycerin. Unstable ischemic heart disease, on the other hand, is more like a sudden accident. It's part of the acute coronary syndrome spectrum and often involves a plaque rupturing, triggering a blood clot that suddenly restricts blood flow.
So much more dangerous.
Much more. This can cause chest pain even at rest or symptoms that are rapidly getting worse.
And the ACS spectrum itself has layers based on how much injury there is and what shows up on an EKG.
Right. Unstable angina is that unstable situation without detectable acute heart muscle damage yet. And STEMI non-ST elevation MI means there's evidence of acute heart muscle damage, but the EKG doesn't show that specific elevation pattern.
Okay.
And STEMI ST elevation MI is the most urgent. An acute, complete blockage causing a heart attack across the full thickness of the heart wall, which typically shows up with that specific ST segment elevation pattern on the EKG, needs immediate reperfusion.
Got it. STEMI's the big emergency.
Correct. The sources also differentiate MI types. Type 1 is the classic heart attack from a blood clot on a ruptured plaque atherothrombosis.
Okay.
Type 2 is an MI caused by that supply-demand imbalance, but not due to an acute clot in the coronary artery itself. Think extreme stress, severe anemia, or very fast heart rates straining an already narrow vessel.
So the same outcome, heart muscle damage, but different immediate cause.
Precisely. And crucially, they note that heart muscle injury from non-ischemic causes, like myocarditis, which is inflammation of the heart muscle, is a separate thing altogether. It's myocardial injury, but not technically an MI.
That distinction seems important for treatment.
Very important. And it's not just classic plaque, though, causing the supply-demand issues. The sources mention other things, too.
Like what?
Issues with the endothelium, the inner lining of the vessels, or microvascular disease affecting the tiny vessels, vasospasm, where the artery itself clamps down, non-atherosclerotic problems like congenital defects or inflammation of the arteries, arteritis, and conditions that massively increase the heart's workload, like severe aortic valve disease or certain types of cardiomyopathies.
So it's a wider net than just cholesterol plaque.
It really is.
So let's break down what the pain feels like with angina, drawing from the sources.
Well,
Pressure, squeezing, or heaviness is classic.
and that's what you often hear.
Right, but the sources emphasize it can be much vaguer, just an uncomfortable feeling, numbness, burning, or even a mild tightness.
Yeah, that vagueness is a challenge. They also point out patients might use the word sharp just to describe how intense it is, not necessarily that it's pleuritic, like related to breathing.
That's a good clarification. What about location?
Location is key, but not always straightforward. Usually it's behind the breastbone, retrosternal, but it commonly radiates.
Where does it typically radiate?
The sources detail classic spots. The ulnar surface, the pinky side of the left arm is common. The right arm, too. Or both arms.
Both arms.
Yes, and they specifically note that radiation to both arms has a high association with MI. Also, the neck, jaw, shoulders, sometimes the epigastric area, the upper abdomen.
Right.
But pain felt only above the jaw or below the upper abdomen is rarely angina. And highly localized pain, something you can point to with one finger, that's also unusual for angina.
Good rules of thumb.
And
The pattern?
timing.
Vital clues.
Yeah.
Stable angina has a gradual onset, builds over a few minutes, peaks, and then resolves in minutes with rest or nitro.
Predictable.
Generally, yes. Unstable angina is either happening at rest or getting worse rapidly, easier to trigger. A heart attack, an MI, is usually more severe, lasts longer, often 30 minutes or more, and isn't relieved by rest. Maybe partially, but not fully.
Okay. Duration matter.
It does, and I find this part fascinating. The sources touch on how the pain is generated. It's thought that when the heart is starved of oxygen, it excites nerve endings, chemosensitive and mechanoreceptive receptors in the heart muscle.
Right.
These signals release substances, activate sympathetic and vagal nerves that travel back to the spinal cord. And because the nerves from the heart enter the spinal cord near nerves from the arms, jaw, neck, shoulders,
Oh,
the brain can get confused and interpret the pain as coming from those areas. That's referred pain. Convergence in the spinal cord.
That makes sense why the radiation patterns happen.
Mhm.
Okay, moving beyond the heart muscle itself, what about other issues in the chest? Other cardiopulmonary causes?
Right. There are other things. Inflammation of the sac around the heart, pericarditis is one. The pain here is often linked to irritation of the pleural lining nearby.
The lining of the lungs.
Exactly. So it's typically pleuritic, worse with a deep breath or cough. Sharp.
Okay.
A key feature is how position affects it. Often better sitting up and leaning forward, worse lying flat.
That's a classic sign.
It is. And it can radiate to the shoulder ridge, the trapezius or neck because of irritation of the phrenic nerve, which goes to the diaphragm. You might hear a distinctive scratchy sound, a friction rub on examination, though not always.
Okay, pericarditis. What else?
Other types of heart muscle injury that aren't ischemia, like myocarditis, heart muscle inflammation, the pain can vary. Could be from the inflammation itself or stress on the heart wall.
And Takotsubo, you mentioned that earlier.
Yes, Takotsubo cardiomyopathy or broken heart syndrome. It's quite dramatic, abrupt chest pain and shortness of breath, often in older women, triggered by severe stress, physical or emotional. Biomarkers go up. EKG can look like an MI, but the coronary arteries are usually clear. The heart muscle is just stunned.
Wow. Stress can really do that.
It certainly seems so.
Mm.
Then there are diseases of the aorta, the body's main artery. These are true medical emergencies. Aortic dissection, which is a tear in the wall,
Right.
a penetrating ulcer, or an intramural hematoma, which is bleeding into the wall, collectively called acute aortic syndrome.
And the pain.
Typically excruciatingly severe and comes on suddenly, like a switch flipped. Hits peak intensity almost immediately.
Is it always that tearing or ripping feeling people talk about?
That's the classic description. And it happens, but the sources note it's often just described as a sharp, knife-like pain.
Yeah.
Very intense.
And location. Does that help?
It can. Pain in the front of the chest often points to the ascending aorta, the part coming right off the heart. Pain in the back, often between the shoulder blades, suggests the descending aorta further down.
Okay.
If the dissection extends, the pain might start anteriorly and migrate to the back. These are incredibly dangerous because an ascending dissection can block off the coronary arteries, causing an MI, cause the aortic valve to leak severely, or rupture into the sac around the heart, causing tamponade, potentially fatal complications.
So incredibly high stakes. Are they common?
Relatively rare, thankfully, maybe 3 cases per 100,000 people per year. But they're strongly linked to high blood pressure hypertension as a major risk factor. Also connective tissue disorders like Marfan or Ehlers-Danlos syndromes, and sometimes pregnancy.
Okay. What about the lungs?
Pulmonary conditions are another big bucket, often coming with shortness of breath, dyspnea. Pulmonary embolism, or PE, a clot in the lung arteries, can cause sudden dyspnea and chest discomfort.
And the pain with PE, is it specific?
It can be confusing. It might be pleuritic, sharp, and worse with breathing if a small clot hits the outer lining of the lung, the pleura.
Okay.
But with massive PEs, you can get severe central chest pain or pressure, maybe heaviness. That feels just like an MI.
Why is that?
The sources suggest it's from the pulmonary artery stretching, or from the right side of the heart being suddenly overloaded and strained, RV ischemia or strain. Things like fainting, syncope, or low blood pressure, hypotension can happen with large PEs too, indicating RV failure.
So PE pain can mimic MI. Good to know. What else from the lungs?
Spontaneous pneumothorax, a collapsed lung. That's typically sudden onset, sharp pleuritic pain. Shortness of breath can actually be mild sometimes, which might lead to a delay in diagnosis.
Oh, gets that.
Risk factors include being a tall, thin male, smoking, or having underlying conditions like Marfan syndrome. A secondary pneumothorax, which happens in people with existing lung disease like COPD, is often more severe. And then there's tension pneumothorax.
That sounds bad.
It is. Air gets trapped in the chest cavity and builds pressure, squashing the lung and heart. That's immediately life-threatening. Needs urgent decompression.
Okay. Any other lung causes?
Sure. Pneumonia, or even tumors near the surface of the lung, can irritate the pleura and cause that sharp, knife-like pleuritic pain. Chronic pulmonary hypertension might cause angina-like pain, perhaps from the right ventricle struggling. And conditions like asthma usually cause chest tightness and breathlessness, but not typically that sharp pleuritic pain.
Okay, shifting to the non-cardiopulmonary causes, which, as we noted earlier, are actually the most common overall diagnoses according to the sources.
Right, the GI stuff and musculoskeletal mainly.
Gastrointestinal issues are huge here, making up over 40% in some data sets. And the pain they cause can be remarkably similar to cardiac pain.
Yeah, this is one of those critical insights from the sources. Just because it feels like a heart attack doesn't mean it is. Esophageal problems are big culprits.
Like heartburn. GERD.
Yes, GERD, gastroesophageal reflux disease, is very common. Also, esophageal motility disorders, where the esophagus doesn't contract properly. And the sources specifically point out that esophageal spasm can feel intensely like angina.
How so?
Squeezing, retrosternal pain, and here's the kicker. It can sometimes get better with nitroglycerin or calcium channel blockers, just like angina. Makes it very hard to distinguish sometimes just based on that.
Wow, okay, that's a real confounder.
It is. Tears like Mallory Weiss, often after vomiting, or even a full rupture like Borhave's syndrome are also mentioned, though Borhave's is rare and very serious.
What about ulcers?
Peptic ulcers, while typically causing pain in the upper abdomen, the epigastrium, can radiate to the chest. The timing is often a clue. Pain maybe 60–90 minutes after eating, potentially relieved by food or
And
antacids.
gallbladder.
Biliary pain, like from gallstones or cholecystitis, is usually in the upper right abdomen, but the pain can radiate widely to the epigastrium, the back, lower chest, or sometimes even the right shoulder blade or shoulder. It's usually a steady, severe pain that lasts for hours.
Okay, pancreas.
Pancreatitis typically causes deep, aching upper abdominal pain, often radiating straight through to the back. Can be very severe.
So a lot of GI mimics. What about muscles and bones?
Right.
Musculoskeletal.
Also incredibly common, making up close to 30% in that chest wall syndrome group. This is anything involving the muscles, bones, joints, or nerves of the chest wall, neck, or arms.
Like costochondritis, I've heard of that.
Exactly. Costochondritis, or Tietze's syndrome, if there's swelling, is inflammation of the cartilage connecting ribs to the breastbone. Very common. It causes tenderness right over those joints that you can reproduce by pressing on them.
So if it hurts when you press, it's not the heart.
Ah, careful there. Here's another critical insight: the source's stress. Chest wall tenderness does not rule out a heart attack. You can absolutely have both conditions at the same time. Maybe the patient strained their chest wall because of the heart pain.
Okay, that's a really important point. Don't get falsely reassured by tenderness.
Definitely not. Other MSK causes: issues in the neck compressing nerves, cervical radiculitis can send aching pain to the upper chest or arms, often worsened by neck movement.
Like a pinched nerve.
Sort of, yeah. Other culprits include nerve pain from shingles, herpes zoster, which causes sharper burning pain in a dermatomal pattern following a nerve root distribution, usually happens before the typical rash appears.
Ow.
Or just simple muscle strains from coughing hard, unusual activity, or minor trauma. Tendinitis, bursitis in the shoulder can mimic radiating pain, even intercostal muscle cramps.
And how does that pain feel?
Trauma or strain to the chest wall itself usually results in a constant localized ache that gets worse with specific movements or when you press on the sore spot.
Okay. And the last category, psychological.
Yes, psychological factors account for a significant portion, up to 10% of ED visits for chest pain, according to some sources. Panic disorder and generalized anxiety are common here.
What's the pain like then?
It's variable, sometimes fleeting, stabbing pains, sometimes prolonged tightness or aching. It's often associated with other symptoms of panic, shortness of breath, racing heart, dizziness, feelings of dread or impending doom. The situational context is often a key clue.
So that's the incredibly wide landscape of possibilities. Phew. Given this complexity and the urgent need to not miss the life-threatening ones, how do clinicians actually navigate this? What's a professional approach?
The sources hammer home the absolute initial priority. Figure out if the patient is clinically stable and immediately estimate the likelihood of those immediate life-threatening causes we talked about.
Remind us again.
ACS, aortic dissection, pulmonary embolism, tension pneumothorax, pericarditis with tamponade, or esophageal rupture. Those are the can't-miss diagnoses.
Right, get those on or off the table fast.
Exactly. They structure the thinking process with a series of questions, almost like branching pathways from table 14 to 2 in the source material. Is this acute and life-threatening?
Okay.
If not, is it chronic but potentially serious if ignored?
Right.
If not, is it acute but treatable, not immediately life-threatening? Or is it something chronic that can be treated maybe less urgently? It helps frame the evaluation.
And the history. You said that was paramount.
It's the cornerstone. You cannot overstate its importance. The clinician is essentially interviewing the pain. What does it feel like? Quality. Where is it precisely? Location. And does it travel? Radiation, how did it start? And how long does it last? Pattern duration. What makes it better or worse? Provoking alleviating factors. And what other symptoms came with it? Associated symptoms.
Let's break those down again.
Quality. Reiterate that quality isn't definitive alone, but it guides your suspicion. Pressure tightness points towards ischemia. Sharp pleuritic suggests pleural involvement, like pericarditis or PE or pneumothorax. Tearing ripping is classic for dissection, though often just severe sharp. Burning could be GI, but sometimes ischemia too. And remember, sharp might just mean intense to the patient, not necessarily pleuritic.
Okay. Location specifics.
Location and radiation are potent clues. That radiation to both arms is highly suspicious for MI. Pain radiating up to the trapezius ridge, the shoulder muscle, is classic for diaphragmatic irritation, like in pericarditis. Highly localized pain, pinpoint pain, is unusual for angina. And severe pain going straight through to the back, especially between the shoulder blades, is a huge red flag for aortic dissection.
Pattern details. Onset.
The pattern tells a story. Building over minutes suggests ischemia. Sudden peak intensity onset suggests dissection, PE, or pneumothorax. Fleeting pain, lasting only seconds, is very rarely ischemic. Pain that's been constant for many hours or days without other concerning signs is unlikely to be acute ischemia, though chronic stable angina is different.
Provoking alleviating factor.
Crucial. Activity or stress triggering pain relieved by rest. That screams ischemia. Though sometimes warm-up angina occurs where it gets better with continued mild exertion. Positional changes affecting the pain. Think pericarditis or musculoskeletal, pain related to eating. Points to GI, though remember postprandial angina can happen with severe blockages after a big meal increases heart demand.
Okay.
Relief with antacids, strong GI clue. And the response to nitroglycerin is suggestive of ischemia, but not definitive. It also relaxes esophageal spasm. Plus, if it takes more than 10-15 minutes to work, it's likely not simple angina, or perhaps it suggests a severe MI that isn't easily relieved.
Nuances everywhere.
Ugh.
Associative symptoms.
They add more pieces to the puzzle. Sweating, diaphoresis, nausea, vomiting, shortness of breath, dyspnea, feeling faint or actually passing out, syncope. These can all accompany urgent causes like MI, PE, dissection.
Right.
Sometimes these are the main symptoms acting as anginal equivalents, especially in women and older adults who might not have classic chest pain. Just sudden shortness of breath or fatigue or nausea.
That's important to remember.
Very. Dyspnea suggests cardiopulmonary but isn't specific on its own. Coughing up blood, hemoptysis points towards the lungs, PE, pneumonia, tumor. Nausea and vomiting might suggest GI, but can also happen with an MI, especially an inferior MI affecting the bottom part of the heart due to vagal nerve stimulation.
You would put all this together with their history.
Exactly. You overlay all this on the patient's past medical history. Do they have risk factors for atherosclerosis, smoking, diabetes, high blood pressure, high cholesterol, family history? Risk factors for blood clots, VTE. Do they have a history of panic attacks or a connective tissue disease like Marfan? This context is vital for calculating that initial pre-test probability.
Okay, history is huge. What about the physical exam?
The physical exam, while potentially normal even in serious conditions, is still critical. It helps assess stability and find specific signs.
What are you looking for generally?
Just looking at the patient tells you a lot. Are they anxious, pale, sweaty, struggling to breathe? Are they clutching their chest, the so-called Levine sign? Do they have the body habitus of Marfan syndrome, tall, thin, long limbs? Or maybe a thin young man suggesting higher risk for pneumothorax?
And vital signs.
Non-negotiable. Tachycardia, fast heart rate or hypotension, low blood pressure. Major red flags for severe issues: shock from a massive MI, massive PE, tamponade, tension pneumothorax. Hypertension, very high blood pressure, could point to an aortic emergency, though they can also present with low blood pressure if complications occur. Sinus tachycardia is common in submassive PE. Tachypnea, fast breathing, or hypoxemia, low oxygen levels, point strongly to a pulmonary cause. Fever is nonspecific but might suggest infection like pneumonia or pericarditis.
What about specific exam findings?
Specific exams, too. Listening to the lungs, are there crackles suggesting fluid, heart failure? Decreased breath sounds suggesting pneumothorax or effusion? Wheezing, localized findings suggesting pneumonia?
Okay, heart.
Listening to the heart, check the jugular venous pressure, JVP, in the neck for signs of fluid overload or tamponade. Are there extra heart sounds like an S3 or S4 gallop suggesting heart failure or strain? New murmurs suggesting valve problems? Maybe a complication of MI or dissection? That pericardial friction rub?
Abdomen, extremities.
Feeling the abdomen for tenderness, suggesting a GI cause, or liver congestion from right heart failure. Checking the pulses in the arms and legs, are they equal bilaterally? A difference, a pulse deficit, could suggest an aortic dissection has blocked off a vessel feeding an arm or leg. Or maybe signs of chronic peripheral artery disease. Swelling, redness, tenderness in one leg might point to a DVT, a deep vein thrombosis, which could be the source for a PE.
And checking the chest wall itself.
Yes, examining the chest wall for tenderness, like costochondritis. But again, remember that crucial caveat. Tenderness does not rule out MI. Checking sensation, if a nerve issue like cervical radiculitis is suspected.
So the history and physical build the framework and estimate the probability. Then testing comes in to help confirm or rule out specific things.
Exactly. Testing refines the probability. And electrocardiography, the EKG or ECG, is absolutely crucial and should be done rapidly, ideally within 10 minutes of arrival in the ED for chest pain.
And its main job.
Its primary job is to quickly spot a STEMI, that ST elevation MI, because those patients need immediate reperfusion therapy like angioplasty or clot-busting drugs. Time is muscle.
Can it show other things?
Yes, it can also show other patterns that suggest higher risk ischemia like ST segment depression or T-wave inversions. But here's another key insight from the sources. A normal resting EKG is not a free pass, especially early on.
How sensitive is it?
Its sensitivity for detecting ischemia can be quite low initially, maybe only around 20% according to some studies. That's why serial EKGs, repeating them over time, are often necessary if suspicion remains. And right-sided leads might be needed for certain types of MI.
And EKG changes aren't always ischemia, right?
Correct. EKG changes aren't just from ischemia. PE can cause changes like the classic S1Q3T3 pattern or axis shifts. Pericarditis causes diffuse ST elevation, often concave up, and PR segment depression. Even things like electrolyte imbalances or hyperventilation can cause abnormalities. Context is everything.
What about a chest x-ray?
Chest X-ray is standard but often unremarkable, normal in the acute phase of many serious conditions like ACS or PE. It's most useful for seeing other things clearly. Obvious pneumonia, a collapsed lung, pneumothorax, significant pulmonary edema, fluid in the lungs suggesting heart failure, maybe a widened mediastinum, which is a red flag for aortic dissection, sometimes subtle signs of PE like a Hampton's hump or Westermarck sign, but often normal, or pericardial calcification suggesting chronic pericarditis.
Okay, then the blood tests,
Yeah.
biomarkers.
Yes, cardiac biomarkers, particularly troponin, are the key lab tests for detecting heart muscle injury, myocardial injury. The sources explain these are proteins normally inside heart muscle cells that get released into the bloodstream when the cells are damaged or die.
But there's a delay.
Yes, there's a time delay. It takes time for the injured cells to release troponin and for it to reach detectable levels in the blood. That's why timing is important.
So troponin is the main test for MI.
Troponin is the go-to preferred biomarker for diagnosing MI. The sources advise measuring it in anyone with suspected ACS, but generally not routinely ordering it on every patient with chest pain unless there's some reasonable clinical suspicion for ACS. Though it is sometimes used for risk stratification in other conditions like PE or heart failure, its primary role is ACS diagnosis.
And these high-sensitivity assays, how have they changed things?
High-sensitivity troponin assays have been a major advance. They can detect much lower levels of troponin and detect them earlier after injury starts. They also allow for better detection of changes over short intervals.
So faster diagnosis.
Potentially, yes. They've enabled the development of rapid rule-out protocols, where you might repeat the test just 1 or 2 hours after the first one, compared to the older standard of waiting 3-6 hours or even longer.
How good are they at ruling out MI?
Their high negative predictive value is a key strength. A very low high-sensitivity troponin level, especially if measured more than 2-3 hours after the onset of symptoms, makes an acute MI very unlikely, greater than 99% negative predictive value in many studies. That helps safely identify patients who don't need admission.
But there's a catch.
Yes, this enhanced sensitivity comes with another crucial point emphasized in the sources. High-sensitivity troponins can be elevated, meaning detectable or even above the 99th percentile cutoff in many conditions other than an acute MI.
Like what?
Chronic heart failure, chronic kidney disease, stable coronary artery disease, pulmonary embolism, sepsis, myocarditis, even after extreme exertion like running a marathon. So just seeing an elevated number isn't enough for an MI diagnosis.
So how do you use them?
The clinical context matters immensely. You need to look for a dynamic change, a significant rise or fall in the troponin levels on serial testing. A single elevated value could be chronic injury. A clear rising or falling pattern suggests an acute process. And then you have to combine that with the clinical picture, the history, EKG findings, imaging to determine if the acute injury is likely caused by ischemia. An official MI diagnosis requires evidence of acute myocardial injury, that rising, falling troponin above the 99th percentile, plus evidence of ischemia. Just finding injury isn't enough. Figure 14-3 in the sources has a nice classification.
That makes sense. Injury versus infarction. Any other important labs?
Other labs mentioned include D-dimer. Its main use is to help rule out PE in patients where your clinical suspicion is low to intermediate to begin with. It has a good negative predictive value, but poor positive predictive value. Lots of things can raise D-dimer.
Yeah.
And BNP, or NT-proBNP, brain natriuretic peptide. These are markers of cardiac wall stress, useful in diagnosing heart failure, and they also provide prognostic information in ACS and PE. Higher levels mean worse outcomes.
Okay. With all this info, how do clinicians put it together? especially in a busy ED.
Given the complexity and volume, clinicians often use decision aids and algorithms, sometimes called clinical decision pathways or rules, especially in the ED, to help integrate the information and estimate the short-term probability of ACS or major adverse cardiac events, MACE.
What are some examples?
The sources mention scores like the heart score, history, ECG, age, risk factors, troponin, or EDCS, emergency department assessment of chest pain score. They combine these key elements from the initial assessment
Right.
to categorize patients into risk levels, particularly identifying a group at very low risk, say less than 1% chance of MACE within 30 days.
And the goal is?
The goal is to help identify those very low-risk patients who might be suitable for discharge home with appropriate follow-up, perhaps after a short observation period with serial troponins and EKGs, thereby avoiding unnecessary hospital admissions and further testing for a large group.
Did they work?
They're not perfect. Their specificity isn't always great, meaning they might flag some low-risk people as higher risk. But when used correctly, in conjunction with clinical judgment, serial high-sensitivity troponins, and serial EKGs, they are useful tools for safely identifying that very low probability group. They underpin many accelerated diagnostic protocols, or ADPs, designed for efficiency and safety.
And these are different from scores used after diagnosis.
Yes, it's important to distinguish these ED risk stratification tools from prognostic scores like TMI or GRACE, which are used after an MI diagnosis is made to predict future risk.
Okay. What if someone isn't clearly low risk, but maybe intermediate or uncertain after the initial workup, or needs evaluation later?
That's where further testing, often involving stress testing or coronary imaging, comes into play. This is usually done after immediate life-threatening causes have been excluded. Options include CCTA, coronary CT angiography, or functional stress testing using nuclear imaging or echocardiography.
How do they choose?
Factors like local availability, expertise, patient factors, and previous history matter. CCTA is increasingly used early on, especially in patients with no known history of CAD, whose initial biomarkers and EKGs are normal or inconclusive.
What's the strength of CCTA?
It's very sensitive for detecting obstructive coronary artery disease, meaning significant blockages. Its main strength is its excellent negative predictive value. A completely normal CCTA essentially rules out significant coronary artery stenosis, or plaque, as the cause of the current symptoms. It can also sometimes show signs of myocardial injury or complications, and importantly, it can often simultaneously exclude other critical diagnoses like aortic dissection or pulmonary embolism in the same scan.
So it sees the anatomy. What about functional tests?
Functional stress tests like stress nuclear perfusion imaging or stress echocardiography look at how the heart functions under stress, looking for evidence of ischemia, areas not getting enough blood flow during stress. These are often preferred alternatives, particularly in patients who already have known obstructive CAD, where knowing if a known blockage is causing ischemia is the key question. They are superior to just an exercise EKG alone.
Stress meaning exercise.
Can be exercise on a treadmill or bike, or pharmacologic stress, using medications that simulate exercise for patients who can't exercise adequately.
Okay.
The sources also mention resting myocardial perfusion imaging, doing a nuclear scan without stress. This can sometimes be useful in select patients who have ongoing pain but non-diagnostic tests. A normal resting scan makes significant ongoing ischemia very unlikely. An abnormal scan needs more investigation.
What about the old standard, the exercise EKG on its own?
Discusses its historical role, particularly for lower-risk patients evaluated as outpatients. However, the sources note that evolving evidence suggests that for the very low probability, patients identified by modern protocols using high-sensitivity troponin, routine outpatient stress testing, including just an exercise EKG, may not actually improve outcomes and might lead to unnecessary downstream testing. So there's been a shift away from routine stress testing for everyone deemed low risk after an ED evaluation.
Interesting evolution. Any other non-invasive tests?
Echocardiography and ultrasound of the heart done at rest. Non-stress echo. Not considered routine for all undifferentiated chest pain, but very useful in specific situations. Uncertain diagnoses, patients with non-diagnostic ST elevation on EKG, or unstable patients.
What did it show?
It can show regional wall motion abnormalities where parts of the heart muscle aren't squeezing properly, which can indicate ischemia or prior infarction. It can also detect mechanical complications of an MI, like a ruptured muscle or valve problem, pericardial effusion, and signs of tamponade. It has limited sensitivity for definitively diagnosing aortic dissection, though.
And MRI.
Cardiac MRI, or CMR, is a very versatile tool. It can do stress perfusion imaging, provide detailed anatomical evaluation, and use contrast enhancement to detect and characterize myocardial injury, helping distinguish between ischemic injury, MI, and non-ischemic injury, like myocarditis. It's usually not used in the acute urgent setting for chest pain diagnosis, but it's valuable for more detailed evaluation later, and it's highly accurate for aortic dissection, although usually CT is the faster first choice in suspected dissection.
So a lot of complex tools and strategies. This leads to the idea of critical pathways.
Exactly. All this complexity, the high volume of patients, and the need for speed and safety have led to the development of critical pathways or dedicated observation units, often called chest pain units or CPUs.
Why do these exist?
They exist specifically to handle this challenge. How to quickly identify the small number of high-risk patients, like STEMI, needing immediate action, while efficiently and accurately evaluating the large number of low to intermediate risk patients to determine who needs admission versus who can be safely observed, tested, and potentially discharged, avoiding unnecessary hospitalizations and resource use.
What are their goals?
Their aims are typically rapid identification and triage of high-risk patients to the right therapy, like the cath lab for STEMI, accurate identification of the genuinely low-risk group suitable for safe discharge, and efficient use of those accelerated diagnostic protocols, ADPs, using serial biomarkers and EKGs, sometimes combined with early imaging like CCTA to reduce evaluation time and costs.
They work?
The sources indicate that studies generally show these pathways and units can decrease costs and the duration of evaluation without any detectable increase in adverse outcomes like missed MIs. So, yes, they seem to be effective.
Okay. What about outside the hospital?
Yeah.
Outpatient evaluation.
The sources also briefly touch on chest pain evaluation in the outpatient setting, like in a primary care doctor's office. Chest pain is common there too. Lifetime prevalence might be 20–40%. And apparently over a quarter of patients who do have an MI saw a primary care provider in the month before.
So it's seen often there too. Is the approach different?
The diagnostic principles are the same. Think about the broad differential, focus on the history and physical, use an EKG, but the context is different. The pretest probability of an acute life-threatening cause, like ACS or PE, is generally much lower in the ambulatory setting compared to the ED.
So less intense workup usually.
Generally, yes. The evaluation typically relies heavily on a detailed history, careful physical exam, and an EKG. Those ED risk scores and decision aids are less validated and less useful in this lower prevalence setting.
What's the main takeaway for primary care?
The crucial takeaway emphasized in the sources is this. If the clinical suspicion for ACS is high enough, based on the history, exam, or EKG, that the primary care clinician is even considering ordering a troponin test, that patient should be referred immediately to the emergency department for a full acute evaluation. Don't try to manage potential ACS as an outpatient.
That seems like a very clear line. Okay, that was a whirlwind tour through the complexities of chest discomfort. Let's shift gears now, if we can, to abdominal pain, which the sources also describe as incredibly challenging, requiring excellent clinical judgment.
Absolutely, just as complex in its own way. The fundamental task is the same as with chest pain, distinguishing those conditions that need urgent intervention, often surgery, from those that are self-limited or can be managed non-urgently.
Again, the history and physical are key.
Paramount. They emphasize yet again the critical importance of a meticulous, detailed history and physical exam. This is where you gather the essential clues to narrow down the possibilities and focus your thinking before jumping to tests.
What are the common reasons people get admitted for abdominal pain?
Based on the source material, the most common causes for presentation on admission seem to be non-specific abdominal pain, meaning they couldn't pinpoint a specific diagnosis despite evaluation.
Interesting.
Acute appendicitis, pain of urologic origin like kidney stones, and intestinal obstruction.
And they mentioned terminology. Something about acute abdomen.
Yes, they note that the older term acute or surgical abdomen is now considered unacceptable because it can be misleading. Not all acute abdominal pain needs surgery, and not all surgical conditions present acutely.
Okay. What are some key learning points they stress about abdominal pain?
A couple of really important ones. First, most episodes of acute abdominal pain are actually self-limited and resolve without specific treatment.
That's reassuring.
It is, but and this is vital, they state clearly that the intensity of the pain does not necessarily correlate with the severity of the underlying condition.
Really? So mild pain could be serious.
Exactly. Mild pain could indicate an urgently correctable disease like early appendicitis, or even a strangulated hernia sometimes. And conversely, very severe pain might be from something less dangerous, like gas pains or gastroenteritis. You can't judge severity by pain level alone. Also, they specifically mention that relying on whether the patient is hungry or not, presence or absence of anorexia, is unreliable for diagnosis.
Good points. So what are those key history components they look for, similar to chest pain? Table 15.1 gives a good overview.
Very similar framework. Age is important context, as different conditions are more common at different ages. The time and mode of onset, sudden versus gradual. Pain characteristics, sharp, dull, cramping, constant, intermittent. Duration, how long has it been going on?
Location too, right?
Absolutely. Location and radiation, where does it hurt most? Does the pain move or travel anywhere? And associated symptoms are critical. Nausea, vomiting, anorexia, loss of appetite despite its unreliability alone. Changes in bowel habits, diarrhea, constipation, bloody stool. And in women, a detailed menstrual history is essential.
And they dive into mechanisms of pain.
Yes, they detail one specific mechanism, inflammation of the parietal peritoneum. That's the lining of the abdominal cavity itself.
What's that pain like?
It's typically described as steady and aching, and importantly, it's usually located precisely over the inflamed area.
Why so localized?
Because the parietal peritoneum is supplied by somatic nerves, like the nerves to the skin, which allow for precise localization, unlike the visceral pain from the organs themselves, which is often vague and poorly localized. The intensity of this peritoneal pain depends on the type and amount of irritant material, for example. Sudden release of sterile acidic gastric juice from a perforated ulcer causes intense pain quickly, whereas bacterial contamination might build more slowly.
Okay, that makes sense.
Yeah.
So bringing it all back together then, for both chest and abdominal pain.
It really comes down to a systematic, detailed approach, relying heavily on the clinician's detective work through that history and physical exam before strategically using targeted testing. You can't just order a battery of tests and hope the answer pops out.
The core challenge, and why mastering this is what, separates adequate clinicians from truly excellent ones, seems to be wading through that immense list of possibilities.
Exactly.
Understanding the subtle ways serious conditions can present, sometimes atypically, and using all the pieces of information, the story, the exam findings, the test results, to confidently distinguish that critical handful of life-threatening conditions from the very large number of benign ones. It's a constant calibration of probability based on integrating everything.
Well said. It's pattern recognition informed by science and experience.
So what does this all mean for you listening? Hopefully this deep dive provides you with a better understanding of why these seemingly simple symptoms, chest discomfort, abdominal pain, are actually so complex from a medical standpoint.
Yeah.
And you can appreciate the intricate diagnostic process clinicians go through.
Yeah, hopefully it gives a framework for understanding what's happening if you or someone you know experiences these symptoms and seeks medical help, appreciating the detective work involved.
We've covered a huge amount of ground today, exploring the vast differential diagnoses for both chest discomfort, from the heart and lungs to the gut, muscles, bones, and even the mind, and the equally tricky world of abdominal pain. We've emphasized the foundational role of the history and physical exam and how specific tests like EKGs, troponins, imaging fit into the picture.
It's clear that in these areas, even subtle clues are really important, and putting them all together is the key.
Absolutely. So here's a final thought for you to consider, something to mull over. Given that patients don't always present typically, symptoms overlap so much, and even our best tests aren't perfect, especially early on, how much of achieving true mastery in diagnosing these complex conditions ultimately relies on a clinician's accumulated experience and their perhaps subconscious ability to recognize subtle patterns that might go beyond the explicit checklists and algorithms?
That's a fascinating question. The art versus the science of medicine right there.